Good morning, everybody. See, people are filtering in, so it's great to see you back. And we're going to get started here in just a couple of seconds. Yeah, great to see you all. Hope you had a good rest of your day yesterday and are excited for what we have in store for you today. Really great sessions again. This morning, we are going to be starting off with a session focused on federal policy. So yesterday, we had a really deep dive and really important information from the Wisconsin Medicaid and Badger Care side of things. And now today, we get to focus on some of the federal policies that are affecting our work and will continue to affect our work in the year to come. And then later this morning, we will have a session about looking at this work through the lens of trauma-informed care. So if you've been doing this work at all in the past, then you know that it's really important that you think about the holistic side of things, of where consumers are coming from and the kinds of life situations they may be bringing to the table when you interact with them. So before we move into our sessions, just like yesterday, some general announcements and information. I wanted to just give you a heads up that all of the sessions that we're having are both, they're going to be recorded. So we're currently recording today's session as we did with both of yesterday's sessions. Those recordings will be available on our conference website. So you can just go to coveringwi.org and look under the events tab for our conference page, and you will find the recordings. Typically, we try to get them up later in the day, but sometimes it just takes a little while for everything to download properly and get them up. But they will be there in the next few days, if not week. In addition to the recording, we also put any PowerPoints that are available. So not all sessions have PowerPoints, but if they are available, we try to make them in that same space where the recording is. And then on occasion, speakers at their discretion will choose to also have additional content they might want to post after the session. Sometimes that includes if there were remaining questions that were asked and the speakers agreed to try to take those back and get those answered. That's not always a possibility, but if it is, then you will find that content there as well. In addition to that, I wanted to also give a heads up about just a reminder, again, that we will have the 2 post-conference sessions. So those will be on Wednesday, October 5th, and one will be from 10 to 11, and that'll be really geared towards folks who are preparing to become newly licensed in the state of Wisconsin as either a certified application counselor or CAC, or as a navigator, because that process is, there's a lot of pieces, and we know that it can help just to walk through that and see if people have questions and things that we can help address. So that again will be October 5th, that Wednesday from 10 to 11. And we will be posting a link to that session, both on our conference webpage and in forthcoming emails. And I think probably in the morning, we'll be able to share the direct link to what that will be. Further, a little bit later that same day, so again, Wednesday, October 5th at 11:30 to 12:30, we'll be having a more open session for anybody who has questions that pertaining to content you've seen in the conference, and things you may feel like you're still confused about or have questions. That'll be led by Adam Van Spankeren, who is our Navigator Program Manager, and he'll be joined by Maciel Gomez from Wisconsin Department of Health Services. And then I wanted to also take a little bit of time. I'm going to try sharing my screen again today. I think it'll go a little bit better today than it did yesterday. I wanted to focus on a couple slides that we've been sharing if you've joined us early and have seen some of the scrolling slides across the, as things have been, in the introduction, I guess, I wanted to share some information about the enrollment networks that have started up again. Some of them have been continuing since the beginning of the marketplace, and many of them are new. So these are enrollment networks that are across the state, and you can see here folks that you can reach out to for your area. If you're, oops, see, boy, I am not having much luck here. All right, I'm just going to stop sharing and I'll keep talking, but that information will continue to be made available to you, and we'll be happy to share that out throughout the conference. But again, just these are enrollment networks that are really intended as we look ahead to the upcoming public health emergency unwinding, whenever that is going to happen. I reiterate what you heard yesterday, which is we just don't know, but we know it's going to be a big moment. And so these are across the state, and there's also one that is statewide. It is actually our Latino Enrollment Network, and it is intended for those who especially support Spanish-speaking consumers in our state. And so all of these are available to you. They have started up over the past few months. Some of them, like I said, have been in existence since the beginning of the marketplace. In that big moment, when there was a really, there's always a need for lots of coordination, but that was an especially big moment to make sure everybody in a regional area has a place to meet, share information, share resources, and just to make sure you're connected to those in your community that you can refer to, or you can be a referral source for. And so please do reach out. As a central lead on this effort is Caroline Gomez-Tom, who is a Covering Wisconsin's staff person leading this effort. She can be your one-stop spot, I guess, for just connecting for those in your community. And like I said, we'll continue to share those slides in the introductory welcome messages slides as you're entering the conference. So you can find that information each morning, and it's something that we can also be sure to include on our website, and you will find that information there. And I think that's all I wanted to share today. Looking ahead, we will have, as always, an evaluation. We're not going to be sharing that until the end of all of the conference sessions later next week. So be on the lookout for that. And we, as always, really appreciate your feedback. It's very informative. It helps us just to make sure things are on the right track for this content that we're providing. And if Courtney and Jennifer Sullivan are up for it, we can start just a touch early with our first session. Is that a go, Courtney? Would you be good with that?
We are ready.
Right. Thank you. Well, thank you, everybody. And I'm happy to introduce you to Courtney Harris, Covering Wisconsin Outreach and Partner Relations Manager. And I will hand it over to you.
Wonderful. Thanks, Alison. And thank you, everybody, for joining us for day 2 of the conference. For those of you who attended yesterday, hopefully everybody did. You met our host for this morning's federal policy session, who is Jenny Sullivan. Jenny is the Director of Health Coverage Access and leads the Centers Beyond the Basics project, as Alison shared yesterday, which provides training and resources about the Affordable Care Act marketplaces and other health coverage programs. And I know is a huge support to our navigators and navigators across the country. And Jenny has had a number of different roles over the years with national and state stakeholders, really focused on identifying and developing and disseminating information about outreach and enrollment best practices for all of the programs that we work with, Medicaid, CHIP, and health insurance marketplaces. So when you talk to Jenny, you can tell how passionate she is about this work and the work of enrollment assisters in particular. So I'm really excited to have her here to guide us through all of the currently and always frequently moving pieces in the federal policy world in our session that's titled appropriately to 2023 and beyond, moving pieces, federal policy updates on the horizon. And you all got a preview of some of these topics during that opening plenary yesterday. So we're looking forward to diving a bit deeper into some of those topics and hopefully answering some of the lingering questions that you may have had after the session yesterday. So with that, I will turn it over to Jenny to get us started. And as you have questions throughout, please feel free to put them in the Q&A, and we may pause throughout to address relevant questions. Otherwise, hopefully we should have plenty of time at the end to address questions as well. Take it away, Jenny.
Great. Thank you so much, Courtney, and good morning, everybody. Bear with me for a moment. I'm going to attempt to share my screen. Let's see how this goes. All right. Oh, hang on. You think you know Zoom, and then there it is. Okay, you can now see my screen, right?
Yep, looks great.
Okay, terrific. And let me just adjust a couple more settings here. That will help everything go more flawlessly going forward. And let's see. Let's pull that out of the screen. There we go. And let me just see how I'm gonna, if it's gonna let me, good, it'll let me use my keyboard. I'm having a lucky morning. Okay. All right, let's get started. Thanks again so much, Courtney. It is a pleasure and a joy to be with you all this morning. Enrollment assistance is very close to my heart. I used to be a certified application counselor in Virginia, in addition to sort of my health policy day job, and I have deep appreciation for how heartfelt and also super wonky the work can be. And I, much like yesterday, and I promise I don't do this with every session that I present or moderate, but I love the title for today as well. It is obviously a nod to our friend Buzz Lightyear from the Toy Story movies. And his sort of To Infinity and Beyond, although I didn't see the movie this summer, which is kind of shocking because I have elementary school age children, but the theme of the Lightyear movie, I understand from a wee bit of research, was about the value of accepting help and learning, which is usually a hard lesson, that you can't do everything yourself. To be a successful being in the universe, you need to be able to accept help. And I think that's so relevant for today. It's a nice reminder that accepting help even from an enrollment assister is not going to be easy for all of our clients. So just centering it in that piece of things, but also for ourselves. We're going to be going through a lot of very detailed and kind of jumping around different federal policy topics this morning. What I want you to keep in mind is that you don't have to master and own and hold all of this content on your own. You're part of a phenomenal network that is here to support you, to answer questions, to offer resources and refreshers. And if all else fails, you can also always reach out to us at the Center on Budget at beyondthebasics.org. This is literally what we do. We answer folks' technical assistance questions all the time, everything from remind me what the federal poverty levels are to I have this very complicated case that I'm going to take 10 pages to explain to you, and then you're going to help me out. So soup to nuts, we are here to support and help you in your important work. So with that, I will just, let's see if I can get going on the right screen here. Okay, there we go. Okay, so my presentation today is organized to start first by looking at lessons learned from last year, and then cover the new developments coming for the new open enrollment season. And final, we'll talk about a few other important factors that could come into play in your work as assisters this year. But I do want to make sure we have plenty of time for questions and discussion, and I have given Courtney full liberty to interrupt me at any time. I think the topics are disparate enough that it might make sense to interject with questions as we go, just to make sure that we don't sort of lose the thread if something raises a question for you. So feel free to speak up, and we will definitely have time for questions throughout. Okay, so let's first look back at last year and what we can learn from OE9. All right. So the biggest takeaway from last year is how critically important the American Rescue Plan Act's enhanced marketplace subsidies were, which I think most of you probably know if you were in the space doing assistance last year. And this is especially true, of course, for low-income people. Remember that the rescue plan did this by reducing the expected contribution percentages for people and allowing people with income greater than 400% of poverty to get subsidies. So there's sort of two parts there. The expected contribution percentage is 0 for people with incomes up to 150% of poverty. And then it slowly climbs in a linear fashion from 2% to 8.5% for people with income at 400% of poverty and higher. Now, just a little refresher, this is the percentage of a household's income that the person must spend to purchase the benchmark plan, the second lowest cost silver plan in their area. The premium tax credit then is calculated by subtracting that amount, the expected contribution percentage from their income, from the benchmark premium. The difference is what the PTC covers, and then the person can, or household can, take that amount and go shop for whatever plan they want on the marketplace. So what we can see here is that in Wisconsin, enrollment was falling between 2018 and 2021, but then between 2021 and 2022, there was more than a 10% increase in marketplace enrollment, with more than 20,000 additional people enrolling in a marketplace plan. You can also see that, as you might expect with lower costs and the sort of erasing of the cap at 400% of poverty, that a larger proportion of enrollees received premium tax credits last year, or for the 2022 year. Then the average premium that somebody paid after the PTC was taken into account was also lower. It went from $185 a month in 2021 to only $161 a month in 2022, for an average annual savings of $288, which is not astronomical, but at a time when costs for virtually everything else are climbing at a pretty rapid pace, the fact that consumers could purchase a plan for that much less over the course of a year is actually pretty remarkable. And when you take into account, of course, that these are folks with low to moderate incomes in most cases, that is quite a lot of savings indeed. Okay, so lower premiums and greater premium assistance helped a lot, and that's a big takeaway from last year. Unfortunately, as we'll talk about in a minute, those enhanced subsidies are going to continue. But we also had some other changes last year that I think we should keep in mind as we think about how things will go this year. So last year also represented a major increase in investment in in-person assistance. So, of course, which I think this audience in particular is intimately familiar with. After 4 years of federal Navigator grants being at their lowest levels ever, with only $200,000 total allocated for the whole state of Wisconsin, $200,000. Allotments were dramatically increased last year, and then again for 2022. Allotments are more than 14 times higher for 2022 than they were during that 2017 to 2020 timeframe. And again, as I think you all know, but I will just put a fine point on the fact that these investments can be used to increase the number of people who are providing enrollment help, to increase the hours that you're available to provide help, to deepen community outreach connections through events, and to fund more advertising. Although, as we heard yesterday, that's not the most impactful way to spend our time potentially and our money. So we know historically that this kind of in-person help is particularly important for some of the populations with the greatest barriers to enrollment, including very low-income households, people who are immigrants, and people who have limited English proficiency. So this deeper investment in in-person assistance is also paying dividends. And investment in enrollment assistance have never been about numbers, right? They've always been about making sure that people with the greatest barriers can navigate the process. So the combination of deeper investments, both in in-person assistance and reducing the premiums overall, or the increasing the amount of financial help so that we decrease consumers' costs, that combination is what I think led to the powerful enrollment gains that we saw last year. Okay, and I hope you appreciate the nod I did on the last slide to Wisconsin with my red bars for Wisconsin. That was intentional. Okay, so finally, Last year, the open enrollment period, of course, for healthcare.gov states, including Wisconsin, of course, was a month longer. It ran from November 1st through January 15th instead of ending on December 15th as it had in several years past. So this calendar, of course, will continue again this year. And providing people extra time to select a plan can help take the pressure off during the stressful holiday season. It can also give people who are auto-enrolled in December an additional chance to go back and make a change if that auto-enrollment isn't what they were expecting or hoping or planning for. And it just stretches this out over a slightly longer time period so that people have more time to make the decision. So all of these changes last year really contributed to the record high enrollment numbers that we saw. And the enhanced APTCs, as I mentioned, were extended through the Inflation Reduction Act, which was passed by Congress last month. Gosh, it was still only last month. It was in August. So those were extended for another 3 years through the end of the 2025 plan year. So the lower premiums, those sort of lower expected contribution percentages will continue for the next 3 years. So with that, let me just pause and see if there are any questions before I really roll up my sleeves on the federal policy. Anything that we need to address now, Courtney?
Not any yet, Jenny.
Okay, perfect. I'm telling you all what you already know, which is what was going on in the trenches and all of the great improvements last year. So maybe I shouldn't be surprised. Okay, but now let's turn a page and talk about federal policy developments for this year. Okay, so I've already talked about this a lot, but just to really hammer it home, here's another way to show the impact of the enhanced subsidies. So the bold column is the expected premium contribution percentage with the dollar equivalent based on a single adult's income in 2022. And remember, we're going to be using the 2022 federal poverty levels to calculate eligibility for marketplace coverage in 2023. So for people with income up to 150% of poverty, the percentage is 0, which means that they can get the benchmark plan in their area for no monthly premium. Now before the Rescue Plan Act, expected premium contributions for people with income between 100 and 150% of poverty ranged from 2.07 to 4.14%. So we really have ratcheted down the amount of money people are expected to pay out of pocket for a silver level plan. And also remember that everyone with income, we removed the sort of ceiling on premium tax credits at 400% of poverty. That doesn't mean that everybody with an income over 400% of the federal poverty level qualifies for a premium tax credit. They do if they meet other eligibility criteria, and a benchmark plan would cost them more than 8.5% of their income. So of course, as incomes go up, it's naturally going to phase out because the cost of the benchmark plan is not infinite. It's a single number, and when incomes get higher, people won't qualify for the credit anymore. But it is incredibly helpful erasing that ceiling, particularly for older enrollees for whom, with age rating, their costs for their premium costs can be quite high, and for people who just live in expensive rating areas. One more way to show this, just a way to show that where we were before, and I'm looking over because my screen is over here where I can see the slides, but the blue line is showing us where we were before, the orange line is where we are now, and we can see that it extends off to the right of the screen because we don't have that 400% ceiling anymore. Okay. A few other reminders about thresholds that change every year, and we do have a resource, Beyond the Basics creates an annual resource that many of you are probably familiar with. It's just a double-sided sort of quick desk reference to all of these numbers so that you can have them handy. I already have been using it a lot just to update our own presentations and webinars, let alone actually providing enrollment assistance. So there are a lot of useful figures on here. But those include the poverty guidelines, and we've got both the 2022 and the 2023, the 2021 and the 2022 federal poverty guidelines on here. 2021 is relevant as we're helping people reconcile tax credits from this past year, because that was what was used to get people coverage in the marketplace for 2022. Then we'll use the 2022 guidelines for 2023 coverage. We have the threshold for what's considered affordable employer-sponsored insurance. That changes every year, and the threshold for 2023 is 9.12%. So employer-sponsored coverage that costs more than 9.12% of income is not considered affordable, and people can get premium tax credits, assuming they meet other eligibility criteria. We include the annual out-of-pocket max thresholds. These, of course, have gone up a bit. They inch up every year or so. Last year, the single amount was $8,700 for an individual. So you can see that it's up to $9,100 now. And remember that the out-of-pocket max includes spending on covered in-network healthcare services. It doesn't include premiums. It doesn't include spending on services that the plan doesn't cover or that are delivered by an out-of-network provider. And the amounts that you'll see on the slide here are for an individual, and then the amounts for a family are double those numbers. That's all on the cheat sheet too. The affordability exemption threshold for catastrophic coverage is 8.17%. This is not a number you'll use as much, but people age 30 and older can qualify for a catastrophic plan if their marketplace coverage or employer-sponsored insurance costs are more than 1.7%, excuse me. And then finally, we've got the tax filing thresholds for the 2022 tax year, and then the repayment limits for premium tax credits, which is, we get asked about that a lot. So that's a handy number to have at your fingertips as well. And remember that although there's no limit for people, there's no sort of income limit for people with income 400% or higher on what they have to pay back if their income goes up and they receive APTCs. Because people in that income range now qualify for PTCs, that actually reduces their repayment, what they're going to have to repay by a significant amount in some cases, because you can actually subtract what they're eligible for from what they got, instead of just saying if you're above 400%, you have to pay everything back. Okay. So now let's get into the nitty-gritty details. We always get a deluge of federal policy updates in the annual payment notice that CSIO issues, and this year is no different. So we'll start with and a lot of these, I'll just say as an overarching remark, are reversing things that the previous administration either did or stopped doing, depending on the policy. So the first is reversing a policy around lockouts. Now, insurers can't lock people out of enrollment in a marketplace plan due to past due premiums. So this is an important change that says issuers can't prevent people who have past due premium debt from enrolling in coverage for a future year. And they can't apply premium payments for a new plan to past due debt. There are some interactions with grace periods here that if we want to get really in the details, we can talk about, but I'm not gonna go through those examples right now. The next thing is pre-enrollment verification for special enrollment periods. This is a great change. The previous administration introduced pre-enrollment verification requirements for a lot of special enrollment periods. So they would start with trying to verify eligibility for the SEP with electronic sources, but if that didn't work, then they would require people to submit documents before the special enrollment period could begin and the person could get coverage. Now, this administration has said, this is a barrier to coverage. Providing paperwork and following up with these is administrative burden that we don't need. So for healthcare.gov, they will only be conducting pre-enrollment verification for the loss of minimum essential coverage SEP, not for any other SEPs. Now, this is the most common SEP. More than half of all special enrollment periods granted for the marketplace are for loss of minimum essential coverage, but it still is going to reduce the verification burden for many folks. And they're going to start with electronic data sources. So not everybody with loss of MEC is definitely going to have to provide documents, but if the electronic data sources are insufficient, then the person would have to submit verification. And people that do have to submit verification, again, just a reminder, have 60 days to do that. And then for all the other SEPs, people can enroll and provide verification afterwards. Got it, okay. Okay, moving on to the next one. Healthcare.gov will not require verification for people who attest that they are not enrolled in job-based coverage and or don't have an offer of job-based coverage. This is a wonderful thing as well. It's hard to prove these things, and reducing this verification burden is just a load off of people that are in this situation. So it's a great move forward, and there's a lot in the payment notice about all the factors they took into consideration in putting this into place, and sort of the trade-offs. And I think that they landed on this is important to do because it will help more people get coverage. Standardized plans are back for the 2023 year on healthcare.gov, and we're going to talk more about those in a separate slide in a moment. Let's see, and then the last couple of things here are more related to access, but wanted to make sure to touch on them. The first is network adequacy standards. The previous administration had stopped monitoring and enforcing network adequacy standards and hadn't really done it since 2018. So beginning with the 2023 plan year, CMS is going to start doing that again. They'll be evaluating marketplace plans for compliance, first with time and distance standards, and then in 2024, they'll also start monitoring and doing compliance on appointment wait time standards. Finally, there are stronger requirements now for essential community providers. Remember, these are folks like, or entities like probably some of you in the audience, federally qualified health centers, Indian healthcare providers, other community health centers, safety net and children's hospitals, Ryan White providers, etc. And the threshold has just been increased. So now 35% of available essential community providers in each plan service area have to be in the plan's provider network. Previously, it was 20%. So we're just increasing, hopefully increasing access to care. And then the last thing I'll note that's on this jam-packed slide, that's not from the payment notice, but is a good thing to keep in mind, is that people will not lose APTCs due to having a failure to reconcile status. Reminder, failure to reconcile is when the IRS tells the marketplace these folks have received premium tax credits, they haven't reconciled them. And in the past, if people didn't follow up on that and actually reconcile their tax credits, then they wouldn't be eligible for APTCs going forward, and they would actually, the APTCs would stop. But for several years now, due to the pandemic, due to delays in processing on the IRS's side, the failure to reconcile status has not been acted on by the marketplace. People have retained their APTCs, excuse me, even if they have that status, and that continues to be true for the 2023 plan year. Okay.
Jenny, we just have a couple of questions about a couple of things you covered here that I thought we could run through if you don't mind.
Absolutely.
The first is regarding that change for attestation of job-based coverage. So are there any penalties if folks attest that they do not have job-based coverage, but then it's discovered that they do indeed have job-based coverage?
Not specifically due to that. Now there's the overarching understanding, of course, with the application is that you're attesting under penalty of perjury that everything you state in the application is true, but for healthcare.gov states, they will not be verifying, they won't be requiring anything, and they won't be taking additional steps to verify whether somebody does or doesn't have job-based coverage.
Thanks, Jenny. And then kind of related to that, I'm going to skip down to another one. Because of that change related to job-based coverage, does that also apply to the question of whether or not someone is eligible for Medicaid or has Medicaid coverage, or does that process of kind of ensuring that folks aren't duly enrolled in Medicaid and Marketplace still apply?
That, excuse me, that still applies. That's like a separate arm of the verification process. So this new flexibility only applies to job-based coverage.
Great. And then lastly, regarding the kind of lockout change, if money is owed to an insurer for past due premiums, can the consumer still get coverage from that insurer or that carrier, or do they have to change, or would they have to go to another carrier during open enrollment?
If they're in, this gets into the grace period piece, which we are updating our fact sheet on, and that will be posted on our website, the Beyond the Basics website next week, just so folks know. But if somebody is in an active grace period, then and they re-enroll in the same product or something, another product from the same issuer, they've actively re-enrolled, then the issuer can apply their premium payment, whatever money they receive, to any of the debt. The issuer has the choice of whether that goes to the binder payment or whether that goes to a past due debt. So you're just gonna, I think, want to be really careful and clear with folks that if they do owe premiums back, that they need to get that taken care of if they want to continue to get APTCs. And in some cases, it may be advantageous to switch plans if they're able to make a binder payment for the new year while they're dealing with past due debt on another product.
Okay, thanks, Jenny. A couple of other questions now are coming in, and I know you're not covering these topics later on in the presentation, so I think I'm just going to stick here if you don't mind answering a couple more. So kind of going back to this affordability of job-based coverage and that offer of job-based coverage and the marketplace not verifying them, sort of what prevents someone from choosing the marketplace APTC in place of affordable employer-sponsored coverage? For example, would the IRS still pursue repayment of APTC if it's discovered that someone does have affordable employer coverage?
Sure. I think the most important thing is that people need to tell the truth on their application. And that is, you as an assister can't always adjudicate that. You need to take their word for it if they're telling you something that what they're telling you is true. But if it is discovered that for any reason they weren't eligible for PTCs or that elements of their application were inconsistent, then there is still a repayment obligation there.
And the IRS would still then pursue that repayment if they have employer.
Sure. Yep, they would.
And then just a question regarding COBRA, and if COBRA is considered employer-based coverage for this question of an offer of job-based coverage.
That's a good question. I don't know about verification of COBRA. I think that is much harder to verify, but there's also, I guess, right, if you have enrolled in COBRA, then you can't get APTCs. If you have an offer of COBRA that you've opted out of, then you still qualify. So I think that's really the rule to keep in mind. If somebody actively has it, well, then no, they can't get PTCs. If they were offered it, but they didn't take it up, then they're okay.
That's my understanding as well. Thanks, Jenny. Okay, I think that's all we have for now. So I'm gonna let you keep going. Okay, feel free to get up and refill your coffees, folks. I know it's early and this is weedy stuff. All right, so getting into even more into the weeds with a few of the policies from the payment notice. Let's see. Okay, so standardized plans. What is a standardized plan? This is a plan or a sort of, these are criteria that a marketplace, in this case healthcare.gov for next year, will apply and say you have to have issuer, you have to offer plan if you're participating at all in this marketplace and you're providing a plan at a certain meta level. Let's say they're providing a silver level non-standardized plan, they must also offer what's called a standardized plan. And that is where the terms of the cost sharing are dictated by the marketplace. And what that does, so what the deductible is and what the actual cost sharing to get services are. So what that does is help make it easier for the consumer or for you as the assister to compare plans based on other factors. It sort of cuts out the noise of, well, high deductible, but my costs per visit are lower, and on this plan, the deductible is really low, but I could meet it because the coinsurance is really high. It helps you really just compare apples to apples and look at what the impact of the premium, and then things like network adequacy, or not network adequacy, just the network that's covered for a particular plan. And it helps you compare those things without having the cost sharing kind of getting in the way. Other states are doing this, and in fact, healthcare.gov dabbled in this for a few years, a little while back in 2017 and 2018. But there are 9 states with state-based marketplaces that already offer standardized plans,
In California, they offer only standardized plans. So this is not a new policy by any means, but I think we're still learning what the impact is and how important or not these are. Now, the research does show that in the absence of standardized plans, people do sometimes choose a plan that's literally identical but has a higher premium than another plan that's available to them, which is not in sort of standard economics what you would want. You would want people to choose the least expensive option if it's offering literally the exact same product. So people get confused, and you all know this better than anybody. So in healthcare.gov for next year, we are going to see standardized plans, and they will be differentially displayed. So we haven't seen any screenshots of exactly what these will look like, but they will have some sort of icon or color coding or something so that you'll know that they're a standardized plan. And I'm sure that if all else fails, there'll also be a filter for them. Because the way the rule is structured, it says if you offer a plan in this market at this metal level, a non-standardized plan, then you must also offer a standardized plan. You can do the math. This is probably going to result in more plans. Which is a little bit ironic because the idea behind standardized plans is to help, again, cut through the noise and reduce choice overload. But I think what the administration is thinking is that this is a step in the right direction and that they want to build on this going forward. Right now, they're not limiting the total number of plans that an issuer can have or that can be offered in a marketplace. So the net number of plans available is just going to grow. But hopefully you will be able to at least experiment with these and see if it does indeed make it easier to compare plan choices in your area. But it is somewhat of an experiment, so we'll be interested to hear how it goes. Okay, public charge. We have gotten some good news recently about public charge. A couple weeks ago, the federal government issued a new rule that will take effect in December. And what it basically does is codify longstanding guidance and provide a few new clarifications and protections to guard against the chilling effect that we know public charge can cause. So public charge, I don't know how familiar folks are with this, but as a sort of pathway to getting an eligible immigration status for a long, long time, there has been a requirement that people prove that they are not likely to become wholly dependent on government support as a condition of getting status in this country. It has never, well, it didn't apply to Medicaid coverage other than institution-based long-term care. But the previous administration went in and issued new public charge rules that would have applied it to Medicaid, would have applied it to housing benefits, would have applied it to cash assistance, and a number of public benefits, sort of widening the scope. This administration pushed back on that, overturned that, but needed to issue new rules to say what was in place instead. And that's what we got a couple weeks ago. And it sort of clarifies both that Medicaid, other than institution-based long-term care services, and marketplace coverage do not count as a public charge for purposes of gaining immigration status. Excuse me. The clarifications also make it clear that the government will only look at an individual's own use of benefits for purposes of determining public charge, and not like their dependents, other people in their household. And they made some clarifications that there are certain kinds of long-term care that don't count as public charge. It's a big rule. There's a little more to it than that, but just wanted to sort of get the broad word out there. What this is another step in the right direction to help push back against the chilling effect that we know the threat of public charge has on immigrants who are eligible for Medicaid and marketplace coverage, but sometimes don't always feel comfort in applying for them. But we'll need to get the word out. That's really the bottom line. Okay. So this is maybe my favorite part of what I get to talk about today. I wish it were final. I wish it had come out, but we are eagerly awaiting a fix to the long thorn in our side family glitch. This, of course, is the rule that says when we're looking at whether an offer of employer coverage is affordable for a household for both the employee and the employee's family members, we look at the cost of whether the cost of employee-only coverage is considered affordable. We know what this does is lock lots of people out of coverage, because even though they don't have, they don't actually have an offer of affordable coverage. They either can enroll in full cost marketplace coverage, or they can enroll in what is likely very expensive family coverage through an employer offer. So earlier this year, the IRS issued a new rule, proposed rule that would overturn, well, that overturn is probably too strong, that would reinterpret the affordability test to look at the cost of family coverage when assessing affordability for the family members. I'll walk through a couple examples here in a minute, but the thing to keep in mind, hopefully, and if the rule is finalized, which we expect it really is imminent, and it really should be finalized before the beginning of open enrollment, and so it would apply to the 2023 coverage year. The one thing to keep in mind is the possibility that you have an employee who has who has to take their employer coverage, basically, because it's considered affordable, but you have family members who qualify for coverage through the marketplace. You want to help them understand that they're going to be paying premiums for the whole group, and maybe to do some of the math and make sure that that financial equation still makes sense for their budget. But it opens the door and creates some new possibilities for folks, which is really exciting. So I'm going to walk through things. Apologize, because I'm going to be looking at my screen, which is over here, so I won't be looking right at you for a couple slides. But let's walk through an example. Monica and Roberto are married. They have 2 kids. Their household income is $40,000 annual, of course. Monica has an offer of employer-based coverage that would cost her $150 a month. They also offer family coverage, which would cost the family $450 a month. Family coverage is too expensive, so Monica wants to know if her family qualifies for APTCs. So under current law, we're only looking at that offer of employee-only coverage, $150 a month. $150 a month is equals 4.5% of their overall income, which is well under that 9.12% threshold. And so Monica wouldn't be eligible for a PTC, neither would her family, even though the family premium cost would exceed that 9.12%. It would $450 a month would equal 13.5% of their income. If we have the fix to the family glitch enacted or finalized before the start of open enrollment, then Monica's family would be eligible for PTCs because their coverage is unaffordable through the employer. And so the family members, Roberto and the 2 children, would be able to get a marketplace plan together. And this is, again, assuming that all of them are in the same tax household. That's an important factor. Okay, moving right along. We also have a new proposed rule. This is not yet finalized, but I wanted to put it on folks' radar. A new proposed rule to the non-discrimination rules, the 1557 rules that came out after the Affordable Care Act was passed. So the proposed rule would reverse changes made by the previous administration. I see you're probably picking up on the theme here, and expands protections notably for people based on gender identity, among other things, but that's a real strong emphasis. And so what does that mean? Well, the rule prohibits discrimination based on race, color, national origin, sex, age, and disability, and that has always been true. But what this proposed rule does is define discrimination on the basis of sex in more detail. So that includes things like denying or limiting health services or providers' ability to deliver services on the basis of sex. That includes treating someone differently on the basis of sex in a way that subjects them to harm. That includes denying or limiting access to gender transition or gender affirming care. And it means that the entities can't discriminate based on marital, parental, or family status. The rule would also prohibit insurance benefit designs that don't provide coverage in the most integrated community setting appropriate for people with disabilities. And it would prohibit discrimination based on association, discrimination against people with disabilities, and discrimination against people with limited English proficiency. It would also require notices of anti-discrimination protections and availability of language assistance as well as auxiliary aids and services. And it requires covered entities to develop written 1557 plans and procedures and to provide training to staff. So this is not yet finalized. These conditions don't apply yet, but they are working their way through the federal process now. Comments are due in another week or so. And so I think we can expect to see a final rule sometime next year. Okay, last thing here in the sort of the federal updates. If you're year-round assisters, and this is old news to you, but just for folks who maybe are more seasonal or just coming back to this from after a while away, we do have a low-income special enrollment period that continues to be in effect for people with income up to 150% of poverty. This took effect earlier this year. I believe in March is when it first started to roll out. And there was a lot of like, this is wonderful, and when does it go away? And we always had to say, we don't know. It's the way that it's built, it's sort of premised on the availability of zero premium plans for people with income up to 150% of poverty. And so we had to sort of wait and hold our breath and see what would happen with the enhanced subsidies. The good news is those have been extended for another 3 years. And so as long as this administration is in charge of the SEP rules, we expect that this special enrollment period will remain in place. And it does allow people to take advantage of it up to one time a month all year. So it's not true open enrollment, but it's pretty close to saying that if your income is below 150% of poverty and you're otherwise eligible for tax credits, you can come in when you need to get coverage. With that, I think we are up to our first poll question, which I put on a slide, but I know it needs to be Zoomified. So, and this, I got to design this one, so this is my personal curiosity. But which of the following scenarios have you encountered while helping folks this year, since from last year, last open enrollment period to now? Someone getting a higher tax credit than they expected, a household affected by the family glitch, a person or household who qualified for the new low-income SEP I just mentioned, somebody with questions about Medicaid unwinding, although if they had questions, I'm certain they didn't use those terms, or somebody with questions about surprise bills. And we'll talk about the No Surprises Act in a minute too. Let's see, what are our answers? Oh, people did have lots of questions about unwinding. Well, that's good to know. And the rest of these they're all happening fairly frequently across the board too.
Yeah, that was a great question. Thank you for asking that, Jenny. It's helpful for us to see too, I think. So,
yeah, no, that's fantastic.
Very great to know.
Right. While we're paused for a moment here, any other questions that we should address live, Courtney?
I was just going to say, we do have some good ones on the family glitch and a couple of other things. So why don't we go ahead and address some of those?
Sure.
Let's see. So specifically on the fix to the family glitch, if an employee, this is kind of a situation where maybe the employee only coverage is affordable, but the family coverage is not. Does the employee, or would the employee then have a choice of using employer coverage for themselves and the marketplace for the rest of the family, or including themselves in the marketplace plan, or would that individual employee still need to take their employer sponsored plan if that self-only plan is affordable?
Right. That is it. Correct me, Courtney, if your understanding is differently, because I know you're in this too. But the proposed rule doesn't change the affordability test for the employee. So if the employee's individual offer of coverage is below that threshold, then they still are not able to get APTCs. Now, the family could decide that they want to build a household with family members who are getting APTCs and grab that other person who's the employee with the affordable offer of coverage and have that person pay full freight for their marketplace coverage. But again, you're going to have to help folks work through the math. So I think getting familiar with those mechanics is going to be really important.
That's my understanding.
Does that track with your understanding too,
Yeah,
Jenny?
that's my understanding too, Jenny, that it doesn't change the rules around individual affordability. on that affordability percentage, just a clarification of whether the that affordability percentage of 9.12% for plan year 2023, would that be the same percentage when looking at family-based coverage and individual coverage, or is there a different percentage for family members versus individual coverage?
That's a great question. I've never thought about it, but it is the same. There's a single affordability standard.
Great. So it would be 9.12% for both family members and the individual. Oops. And then let's see. If both parents, this is another family glitch fix question. If both adults in the household are working, do they take into account kind of both employer-sponsored coverage options through each employer before evaluating the marketplace option?
Yes. Yep.
So be looking across the family at all of the offered options for that tax household, right?
Right. And that's those are the key words you just said there for the tax household. So we're looking at both of their offers. We're also looking at the entire household income, not just the income of the employee, for example.
All right. Let's see. One more on the family glitch from one of our assisters who says that Minnesota, a state-based exchange, already fixed the family glitch. Are you aware of any other states that have pursued this fix already and implemented it?
I am not, and I'm actually not familiar with what Minnesota is doing, but they must be supplementing with state dollars the assistance that folks receive, because the family glitch is a federal interpretation of federal funds used for APTCs. So that is not a state-based marketplace like option per se.
Okay. And then one question related to eligibility for financial help and marketplace coverage for immigrants and their families. Have you heard any interest from your federal partners at HHS around changing the rules of eligibility for people who have the DACA immigration status, who of course don't currently qualify for healthcare.gov coverage, even though they have a social security number and work permit?
Right. It's definitely on the list and something that our immigration team and their sort of national allies work on. It's not something personally that I have a lot of expertise in, but I know that it's on the list. I wish I don't have more details than that.
Perfect. Thanks, Jenny. And we do have one other question. I think I'm just going to hold for the end to let you keep going, and then we'll come back to some other questions that we had come in.
Okay, sure. And we're getting pretty close to the end anyway. We have gotten through a lot of the nitty gritty. Okay.
Perfect. Thank you.
All right, so advance my slides. So that was our federal policy recap, but there are a few additional considerations just to keep in mind that are policy related that I would be remiss if I didn't mention. You know that one of them is Medicaid unwinding. Heard about it yesterday. I assume that you're hearing about it at other sessions as well. It's really the big thing looming on the horizon that's like about to suck all the air out of the room, but nobody knows exactly when. We have some timeframes, and just to refresh folks on those timeframes, we didn't get 60-day notice as the administration has promised it would give, that it would end in mid-October. The public health emergency is renewed in 90-day increments. So the next due date for it to be renewed is mid-October. And because they didn't give us that notice, we assume that it will be renewed, which takes us to mid-January. So we now expect the public health emergency and hence continuous eligibility in Medicaid to continue through mid-January. The 60-day notice for that, if it's going to end in January, would come to us mid-November. At that point, if we don't hear anything in mid-November, then we can reasonably expect that the public health emergency would then continue until mid-April. And this sort of leapfrogging pattern will just continue until the PHE ends, or until other legislation is passed that would end it by other means, that would end continuous eligibility in Medicaid through other means. And there's some interest in doing that just to give a date certain, to give states, what they need to do this with integrity. So stay tuned. Even as Brenda shared with us yesterday, nobody knows when the hammer is going to fall on this, but when it does, it will set into motion a process of reassessing eligibility for everybody on the Medicaid rolls over the course of 12 to 14 months. And I think you got some really great assurances yesterday that for now, the leadership in your state is committed to doing a really good job with that, which I think is really heartening. That's certainly not the case or not the language that's being used everywhere. But the bottom line is that you all are going to be on the front lines of a lot of this. And I hope that particularly for folks that do this work year round, you're definitely going to be a crucial sort of frontline support for folks as they're navigating these changes either. And I think the thing that we're really most concerned about is people who don't get notice at all, who ignore notices or have moved or don't, for whatever reason, don't get the outreach that's made to them, and then they lose their coverage, and then they don't learn about it until they're trying to seek care. And at that point, they learn that they're no longer covered. And these people who lose coverage for procedural reasons, we don't know whether they're eligible or not. We don't know anything about them at this point. So they could be people who very well are and continue to be Medicaid eligible. If they're not, they're probably eligible for the marketplace in many cases. And that's again, where assisters are going to be so important to help those folks make that smooth transition from Medicaid coverage that they could have had for up to 2.5 or more years with no interruptions to the marketplace paradigm, which is very, very different. How it operates, the fact that in many cases you have to pay premiums. There are a lot of different considerations that as you help people who might be moving from Medicaid to marketplace coverage need to understand. So we've been trying to create resources. I know that fact sheets can only do so much to solve problems like this, but we do have resources on Beyond the Basics. And one of them that I wanted to point you all to, because it's not for you, it's your messengers to get it into the right hands, but it's a 2-pager that, there might be 3 pages actually, but it says in as lay terms as we could come up with what's going on with Medicaid and how it could affect people, and then how folks on the front lines who might be at food banks, who might be homelessness service providers, other folks in direct contact with people at the greatest risk of losing coverage for procedural reasons, helping those community partners understand that unwinding is happening, that they have a role. The part of the role is to get folks either to the Medicaid agency or to someone like you. And so we've mentioned how to look up assisters in a given area, how to reach out to them. And we have translated this particular piece into translated into 7 languages plus English. So hopefully that is something, we would really love it if you can take this and get it out into the hands of folks who need it, who are going to be most likely to be interfacing with people who have Medicaid now, but stand to lose it during unwinding. Okay. Moving right along here. Let's see. The last thing just to touch on is the No Surprises Act. Looking at my slides over here now. This law took effect earlier this year, and it protects people in two instances. It's both people who get emergency care from an out-of-network provider. They can't be billed more than the in-network cost sharing for that emergency care. And number 2, it protects people who get non-emergency care from an out-of-network provider at an in-network facility. They are protected from paying more than the in-network cost sharing amounts for their plan. So this it doesn't apply to folks with Medicaid, but it does apply to folks with marketplace coverage, that is private coverage. And so it's an important protection for folks, but I think it's still getting off the ground. The wheels are a little creaky. Figuring out how all this is going to work is taking some growing pains and some patience at the state and the federal level. State departments of insurance are integrally involved in the rollout and sort of the adjudication process, but it is somewhat like an appeals process. You're going to go to the insurance company, say, hey, this doesn't seem right, see if the provider made a mistake in the billing. The insurer will get back to you. If you need to, you can file an appeal. The next step would be to contact the provider and ask them to correct the bill if they have billed you for sort of a surprise bill that is now illegal. And if they refuse to correct the bill, then you can file a complaint, and that would go with CMS. So there's a page about how it's being implemented in Wisconsin that I've listed here. And we also have an FAQ about it as well. And I don't think that this is front and center in most of your work, but if you come across a consumer who's having issues and you suspect a surprise bill could be in the mix, then it's important to sort of familiarize yourself with these protections and help consumers navigate to the experts who can help them understand what their protections are. With that, I think we're down to our next poll question, and I'm going to slow down. I think I rushed us to answers too quickly last time, so we want to leave it open for a full minute, which will be fun and awkward for everybody, or maybe just me. This one is a fact-based one. So this is really to test your knowledge, although it's okay if you don't get it right. We'll talk about the answer. Which of the following statements is false? I'm going to be quiet so you can actually read it.
All right, we'll give that just another probably 10 seconds, and then we'll close that out.
Great. Thank you. Okay, all right. So the majority is correct. People do not need to reconcile their 2022 advanced premium tax credits is false. People do need to reconcile their tax credits. You always have to reconcile your tax credits, or there was a little bit of forgiveness a couple years ago. But what you might have been thinking of if you didn't select this one was the thing that I mentioned about failure to reconcile and that status. People who have a failure to reconcile status, the IRS is going to say, here you go, HHS, here are these people who haven't reconciled their tax credits. And what CMS or HHS, sorry, I'm getting my acronyms wrong. What HHS is going to do is not act on that information and take tax credits right now away from people who are in that status. People still have to reconcile, and there are still ramifications if you don't. But for now, we've got this sort of forgiveness. It's not really, I shouldn't call it forgiveness. We have got this flexibility so that people are not instantly losing their current PTCs for failure to reconcile. But everything else there, open enrollment does start November 1 and end January 15th of next year. The enhanced PTCs are still available at the same level for the next 3 plan years. We talked about standardized plans, so those are going to be available in Wisconsin and all healthcare.gov states. The last thing about the Medicaid continuous coverage requirement, it does continue through at least January. Now, you could catch me on a technicality there. I could see somebody saying, oh, but they haven't officially extended the public health emergency, which doesn't happen for another couple weeks. And I would maybe give you partial credit there. But the real thing that was false here was D. Okay, with that, I think I see that Courtney has been sharing lots of fantastic resources, both from Cover Wisconsin and from Beyond the Basics. So thank you for that, and welcome folks to join any of our remaining webinars or reference the recordings from the first half of our series that are all available on our website. And special plug for the very last one, which is our first Beyond the Basics webinar in Spanish. It's intended for assisters who help clients whose primary language is Spanish. So that is really exciting and coming up on October 20th. And we would love your help spreading the word that that is available, since this is our first foray into this space. And so we obviously have some list building to do. I appreciate your help with that. But with that, I think we have a healthy amount of time for Q&A, or at least we have about 20 minutes, or until I get too tired. And
Absolutely. Absolutely. And thank you to everybody who's been asking questions in the Q&A. We have just a few, so I'm going to kind of start maybe from some of the more recent things that you covered. We have one about the No Surprises Act and just a clarification of a situation. So when out-of-network emergency services result in being admitted for inpatient services, do you know whether the inpatient services would be covered as in or out of network?
So it wouldn't, through the first part of the No Surprises Act that applies to emergency care, wouldn't apply to those inpatient services. But then you would look at sort of the second part of the No Surprises Act, which talks about whether you're billed by an out-of-network provider for services you receive in network, which is a thing that's a pretty common place where it happens, is if you're admitted for the hospital and you have a provider who comes in and they're not in your network, even though the hospital is, that would also trigger No Surprises Act protection.
Okay. Yeah, this is a bit of a complicated, kind of nuanced issue, certainly. So, and thank you for sharing that OCI resource too, of some local kind of implementation of the rule, and the other contacts that our navigators can use if they're encountering issues or their consumers are encountering issues with this rule. Let's see. One comment that I just wanted to share, because I think it is helpful just to share overall. So we know that particularly during open enrollment, when there are, broad-based promotions and there's just a lot more conversation and awareness raising around health insurance coverage generally, that we might have consumers coming in to enroll in healthcare.gov who may still be enrolled in Medicaid, particularly because of the continuous coverage policy during the pandemic. And so just a reminder for our sisters that it's kind of especially important to screen and confirm Medicaid coverage for those who are sort of newly expressing interest in the marketplace and may, based on income, seem to qualify or seem to fall more in that marketplace income bucket at this moment.
Mm-hmm. And we do expect, I think that's a great point. I'm glad that that somebody raised that. And we do expect during unwinding that there are going to be a lot of flexibilities and potentially some new special enrollment periods or broader rules around existing special enrollment periods, so that folks that might be losing Medicaid coverage can make a smooth transition, or as smooth as possible. I think it's going to be very hard to have no coverage gap or no gap between when Medicaid ends and marketplace coverage begins. Not impossible, but there will be some flexibilities there. I think that will all come out as we get closer to the actual date. But it is still really important to help people understand that if they're in Medicaid now, then they can stay in Medicaid. If they're in Medicaid now and their circumstances have changed and their income has gone up and they would feel more secure getting a marketplace plan right now, they can do that. That this is a rare circumstance where you really would sort of have a choice. You could say, I'm redetermining myself for Medicaid. This is my updated income, and ergo, I'm going to go into the marketplace. I don't think that, for a lot of folks, that's not going to be the budget-friendly decision, but we know that there are low-cost plans available on the marketplace now. There is that enhanced assistance, and some people prefer predictability, and they just want to know, and they don't want to have to deal with a change that's going to come at a time when they're not expecting it. So that's just one, I think, small thing to keep in mind.
Yeah, and I think that would be something that our DHS partners mentioned yesterday, that there are some reasons when folks may lose or end their Medicaid coverage during this time, and one of which is, of course, by request, if folks do request to end their Medicaid coverage. This is more of a marketplace or a healthcare.gov functionality question. So in the application process, there is an indication that marketplace coverage will terminate if a person acquires other health insurance and is no longer eligible for their marketplace plan. But of course, this is not automated. And the folks that this assister has worked with have had to contact the marketplace to get the marketplace plan ended if they acquire other health insurance coverage. And the question is just whether there's any sort of appetite to or possibility of having that be automated at some point.
That's an interesting question. I think it comes up a lot with Medicare in particular, in that sort of intersection, because often you'll have one member who ages into Medicare and other people in the household who still need to keep a marketplace plan. And so how do you navigate that transition without any losses of coverage or gaps? I am not familiar. That hasn't come up. I'll say I'm in monthly calls with CSIO, and I have colleagues that are in a different set of monthly calls. And I would not say this is an issue that has come up in recent months, but it's an interesting thing to keep in mind. So I'm glad that the person raised this, because it agreed it would be much easier if this was not something where you had to actively turn off your marketplace coverage and actively make new decisions for other people in the household.
Certainly. And since you mentioned Medicare, we did have one question about Medicare that I thought I would just raise, and perhaps we can also just share some more resources on this in the chat. And I also just wanted to foreshadow for everyone that we do have a session coming up soon in the conference that it will specifically be covering sort of the overlay and the complications between Medicare marketplace and other forms of coverage. And I've lost, of course, on my screen the exact day and time of that session. I believe it's Monday.
Right.
I'll look for that information. But in the meantime, the question is, can 65-year-olds be on the marketplace if they, or someone who's, eligible for Medicare, be on the marketplace if they do not get Medicare Part A or Part B?
Okay, I'm going to start with a disclaimer that I sort of mentioned yesterday in shorthand, that I don't speak Medicare. I work primarily in the Medicaid and marketplace space. CHIP too. I started working on CHIP. Started my career working on CHIP. But I'm just going to go over some basics around the intersection of Medicare and marketplace coverage, and then hopefully this kind of gets at the questioners what they're asking. So if you have premium-free Medicare Part A, then even eligibility for that. So you don't have to be enrolled in Medicare Part A. If you have premium-free Medicare Part A and you're eligible for that, then you can't get APTCs. You really should be in the market, or should be in Medicare, excuse me. If you have to pay a premium for Medicare Part A, and this is folks who typically don't have the required work quarters to qualify for premium-free Part A, then you only are barred from getting premium tax credits and enrolling in the marketplace if you're enrolled in that. So if you have an offer, you are eligible for Part A premium free, then you can't get marketplace coverage. If you have to pay a premium for Part A, then it only matters if you're actually enrolled. And then the other little piece of things is when somebody becomes eligible for Medicare, they lose eligibility for the PTC on the first day of the fourth full month after they become eligible for Medicare. So they have a little bit of time to make that transition, but on the first day of the fourth month after they become eligible for Medicare Part A without a premium, then they would lose APTC eligibility. And you have now exhausted my my knowledge of Medicare and marketplace for that.
That's perfect. And I did just include a link in the chat to a helpful, or in response to that question. And then I found the session. So perfect title for this Medicare-based session. It's on Monday, October 3rd. It's our first session that day, and it's called The In-Between: Examples and Solutions When Helping Consumers Transition Between Medicare, Medicaid, Healthcare.gov, and Other Forms of Coverage. And we have two really great Wisconsin resources on Medicare who will be speaking in that session. Kate Schilling from the Greater Wisconsin Agency on Aging Resources, or GWAR, and then Vicki Buchholz from our State of Wisconsin Board of Aging and Long-Term Care and the Medigap helpline. So we just really encourage folks to attend that session on Monday, since I know this is a question that comes up for our sisters a lot. So thank you for that, Jenny. I did, since we just have a couple of minutes, I did want to go back to the slide that you had that covered the yearly thresholds and guidelines. There have just been quite a few questions about the 8.17% percentage on that slide versus the affordability kind of job-based 9.12 percentage, and just hoping you kind of help clarify the difference between those two and what they're referring to. I think just in full disclosure, I think our federal training for assisters this year also created some confusion around these two percentages. So if you could just help us clarify those, that'd be helpful.
Okay, sure. So I think the overarching rule of thumb for the majority of the cases where you're going to be thinking about, gosh, is this offer of employer coverage affordable or not? What are we looking at? 9.12. That's your threshold. That's the one that comes into play the most. I think there's a lot that happens in this little itty bitty sort of percentage range, because we also used to have, or we do have 8.5% being the expected contribution percentage for the higher end of the APTCs. So it gets a little confusing. You've got a lot of numbers that are close to each other. But the threshold, the 8.17 is only for folks who, and I just don't, I mean, maybe you will come across a lot of these people. I never did as an assister. But people for whom they wouldn't otherwise qualify for catastrophic plans, they are too old, they are over age 30, but their coverage, their marketplace coverage and their ESI would cost more than 8.1% of their income, then they would be able to, they'd be eligible to purchase a catastrophic plan, which is like a high deductible plan that is not going to cover a lot, but it's there in case of an emergency and you're not going to pay a particularly high premium for that. It's, you know, it's not the high quality essential health benefits coverage that we like in the marketplace. It is just sort of an extra catch-all, but that is what that threshold is used for. Does that help? And is that, I don't know if that's how you all talk about it in Wisconsin either, Courtney. I don't want to override anything that you are using to talk about catastrophic coverage.
Yeah, and I think this slide, that's why I wanted to kind of reshare it again, because I do think it's helpful that the 8.17% is when we talk about this eligibility for catastrophic coverage, like you mentioned, and then the employer affordability percentage that we are typically talking about, like you said, is that 9.12%, that again would be, assuming the family glitch fix, it would be 9.12% in looking at self-only coverage and family coverage for the affordability of that job-based coverage in terms of your qualification for financial help. And I'm just going to put, Covering Wisconsin does have an affordability worksheet too on our how-to sheet page that is really helpful in walking through both that affordability percentage and also something called the minimum value standard too that I know you mentioned, and kind of the quality of that coverage in terms of how much the plan covers for services in the plan. So I'm just going to link to that here. It's on the coveringwi.org/learn page, that affordability worksheet. And then the other percentage you mentioned is that 8.5%. And again, just to reiterate what Jenny said, that is the kind of expected premium contribution. So how much of your income you have to pay towards the benchmark plan in your area. So definitely a lot of percentages out there, but hopefully that slide, which we will be, is posted on our conference webpage, this slide deck for those who asked that question. And then that how-to sheet on the Covering Wisconsin's page will also be helpful.
Wonderful. And somebody, actually a couple of folks mentioned yesterday in the chat when we were talking a little bit about this threshold, what it was last year or what it is in effect for 2022. I believe it's 9.62 maybe. So there's another number floating around in there, a number you might have used last year, or if you have a really savvy consumer, maybe that happens to be a number they remember. That seems unlikely, but the threshold for affordability for ESI is updated every year. So that's why we're looking at 9.12 this year. And it, it makes sense. We've got inflation, right? So the fact that it went down a bit is not a bad thing.
Yep, that's right. So it does change every year. And like Jenny said, that 9.12 is for plan year 2023. So that's why it's helpful in the chat. I know we shared CBPP's yearly thresholds and guidelines webpage, and I think that is a really helpful resource because you can also go back and look at previous years and previous plan years as well on that page. All right, and I think we just have 5 minutes left and we have most of our questions addressed. So I think we can leave it there, and just want to say thank you so much, Jenny, for a really great session. And thank you to everybody who asked really, really wonderful questions. And I know Jenny shared her contact information on the last slide too. And I'll just do a last plug for those Beyond the Basics webinars that I know are happening right now too. So another great way to stay up to date on all of these ever-changing federal policies.
Wonderful. Thank you so much, Courtney, and your colleagues for having me this morning. It's been a pleasure, and please feel free to reach out either through our Beyond the Basics inbox or reach out to me personally. It's just jsullivan@cbpp.org now or 6 months from now if there's ever anything that we can do to help make things clearer for you. Or if you have suggestions for resources that you need or would like to see more of, we are always open to those as well. And thanks so much to Covering Wisconsin for being such a great partner.
Thank you, Jenny. It's been really great to have you. Thank you for making yourself available both yesterday and today and just providing all this really helpful information. And thank you, Courtney, for leading this discussion and all the really great resources that you've been adding in the chat to everybody. So yeah, with that, we're closing out today's session this morning. We will have another one in just a bit. So we're just going to take a short break. We will be back here to start right up at 10:45. Keep this link open. You can just come right back to it, and we'll see you again just about 15-20 minutes. Thanks, everybody. Well, welcome back, everybody. Hope you had a good break and can now rejoin us as we start our second session today. And just a reminder that, as I'm sure you saw in the last session, we aren't using chat, but please do enter any questions that you have as the session goes along in the Q&A function. And if the session coordinator and speakers are able to get to them, they'll be able to answer those. And if you end up using the raise hand function, that's not typically something we can respond to. So if you do have a question, just go ahead and enter that in the Q&A, and we will get to it as soon as we're able. Well, I'm so pleased to introduce this next session, and I will hand it over to Covering Wisconsin's Tina Marszalek, who is a navigator, and she will be leading us through the trauma-informed care topic. So I'll hand it to you, Tina.
Thank you, Alison. Hello, everyone. My name is Tina Marszalek. I am a navigator with Covering Wisconsin, and it is my pleasure to introduce you to the speakers for the trauma-informed care session. First, we have Alison Budzinski. Alison is the Trauma and Resilience Coordinator within the Division of Public Health at the Wisconsin Department of Health Services. Alison coordinates the Resilient Wisconsin initiative at DHS and is passionate about the intersection of public health and adverse childhood experiences. Our next speaker is Sarah Carroll. Sarah is a strategic and organizational development partner on the Human Resources Communities of Practice team in the Office of Human Resources at UW-Madison. Sarah works to introduce the UW Human Resources community to trauma-informed care concepts and to explore ways in which HR professionals might incorporate trauma-informed care best practices and self-care. I'll let them take it away.
Thank you, Tina. I'm going to pull up my screen here. Does it look good on everybody's end? Great. Okay. Hello, everyone. So as Tina just mentioned, myself and Sarah are so excited to be here today to go through Resilient Wisconsin, all things trauma-informed care and how it relates to the work, the critical work that all of you do. So Resilient Wisconsin, a little bit about the initiative. I'm with the Wisconsin Department of Health Services. And like Tina said, I coordinate this initiative that's really focused on how we can build a trauma-informed state and help our helpers. So we recognize there are so many helping professionals, formal, informal, all of you here today are in those helping roles. So how can we think about trauma, toxic stress, adverse childhood experiences through a lens of helping people, which you do every day, but then also for yourself. So you as a helper, what do you need to also think about in terms of being in that helping profession? So we're going to go through kind of some big concepts about toxic stress, trauma-informed care, adverse childhood experiences, and the initiative. So I'll pass it over to Sarah.
Good morning, everyone. It's really wonderful to be with you this morning. We'd like to start off our session in a really intentional way by inviting you to close your eyes for a moment and do a scan of your being in a holistic way. So I invite you to first, and if it helps to close your eyes, all the better, scan your body and do a check for how your body feels as you're here in this conference today. What are you noticing inside your body and around your body? How does it feel? Then check in with your cognitive mind. What thoughts are preoccupying you? What did you come into this space thinking? What might you be thinking about that doesn't have anything to do with this conference? Again, what has been preoccupying your mind? And lastly, consider how you're feeling, both this morning when you woke up and how you joined this conference, and how you're feeling right now. And when a word comes to mind, we invite you to share in a word, or preferably in a word, but in a couple words, how you're feeling. And if you do enter a few words, what we need you to do is put a dash between the words so they stay together. And I'm noticing our hosts that I can't share the results of that poll. I don't know if someone can enable me to do that so that I can, as folks are answering, everyone can see how everyone else is arriving in a word or in a few words. And that way we can, okay, there we go. Let me share that. And I don't see responses yet. I know that the instructions for how to join the poll are in chat. You can access this on your computer or mobile device. If on computer, it's a simple web link. If it's on mobile, you'll text to the number 37607, the code HRCOP716 to be able to join the poll. I'll just give a pause here for a moment. Seeing a range, as we often do in settings this large with so many of you, everything from excited and refreshed to sick and tired, sore and tired, fine, kind of in the middle, frustrated and interested, overstimulated, present and blessed, spread thin, frazzled, tired. And the larger the words get, that symbolizes how frequently that word has been chosen by those of you who are here today. It seems like tired is coming in first. And that might be a collective tiredness from the last 3 years of our global disruption with the pandemic and pandemics of racism, et cetera. And yet, what's really beautiful about this is that there's such a range of presence here. And the reason that we often invite this, how are you arriving space at the top of any work group in my work, or training, or even meetings with colleagues, is to just honor where we're all coming from, and to reinforce that it's truly okay. However you're arriving, we're glad to have you here. And it helps us to understand who's in the space and how you're doing. So we'll leave this up for a while. I won't close this poll, but I think for sake of time, I'll invite Alison, my colleague here, to return us to the program. And again, thank you for being here today in all of the aspects of your humanity.
Thank you so much, Sarah, and thanks to everybody who jumped on that and gave their words. This is beautiful, but also overwhelming too, and I see overwhelmed as a big topic. So if I can share my screen now, it says it's disabled, so here we go. Share. Perfect. Okay, so thanks for your patience, everybody, as we go back and forth. So with that in mind of how we're arriving today, I encourage everybody to, take what you need today and see how this applies to your current frame of mind. And hopefully you can take pieces and implement it in your practice personally and professionally. So we're going to start with just a conversation about stress. And we hear different types of stress all day long. We experience different types of stress, but sometimes it's nice to kind of get on the same page of our conversation about trauma today on how stress relates. So there are 3 categories of stress. The way that Wisconsin DHS kind of breaks it down is that there's that positive stress that we have, and this can happen on a regular basis, and it's actually kind of good for us in the way we can grow, become stronger. Things like deadlines or maybe an interview for a new job. It's stress that it can help you grow, and you actually can overcome it with the tools and the resources you have. Then we have tolerable stress, and this is more intense. It's maybe an experience with an illness, maybe ongoing issues at the workplace, but in the end of the day, you still have, the resources and the tools to buffer yourself around kind of detrimental impacts of it on your kind of well-being and your health. And then we move to toxic stress. And this is the prolonged experience of stress that just cannot be buffered, and you feel unprotected from the consequences of it. So vulnerable populations like children or people who are older or who have disabilities might have more vulnerability to that toxic stress because they don't have that protection around them. But everybody is vulnerable to toxic stress at some point. So it's this experience of toxic stress for a prolonged time that overwhelms your ability to cope in positive and healthy ways. And so again, you can kind of think about this personally, but then professionally with the people that you serve too, kind of where they might fall on that spectrum of stress. And then when we talk about trauma, it's that emotional and psychological and physiological residue that is truly left over in our bodies from living in this heightened toxic stress mode, where we cannot return back to that normal functioning, that we're just on that high alert constantly. So it's that residue that begins to kind of accumulate in our bodies, is one way to frame what that trauma might feel like. So when we talk about trauma, there's different types of trauma, and this list is not exhaustive, but just kind of helps us break down maybe what clients might be experiencing, and then also personally what you might have experienced in your life. So we have acute trauma, and this is sometimes a one-time incident, event, where it can be an experience of danger, violence, a significant loss. Sometimes people categorize this as perhaps a one-time accident. We also have complex trauma. This is sometimes an accumulation of those acute traumas. So maybe there's multiple different things that are happening and piling on, but they're all different incidents and they're kind of building up, and it's that prolonged experience of that trauma. It can also be one type of trauma that's prolonged, such as abuse or neglect that kind of continues on, and there's really no caregiver to assist a person out of it. Then we have historical trauma, and this can come from a cumulative emotional and psychological wound that crosses generations. So examples of this, sometimes talked about as generational trauma, racial trauma. It can go across lifespans that, impact racism or different kind of genocides that have happened in our history. You might not have been alive during the actual incident, but it carries on through generations, and sometimes it carries on through systems. So even if slavery has ended, the racial inequities and systems continue on. So that's one example when we talk about impacts of historical trauma. Then we have sanctuary trauma. This is an experience where you think you go somewhere to be safe, such as a school or a church, maybe a medical doctor, and there's an experience of trauma in that safe setting, which should be a sanctuary. And then vicarious and secondary trauma. And this is kind of what we're going to talk a lot about today is you as a helper. You see on the screen some first responders here, but helping professions range from so many different uniforms and non-uniforms. You can experience vicarious and secondary trauma really no matter what your profession in the helping field is. It's when you see or hear the trauma of another person and you begin to internalize it. So that's the experience of vicarious and secondary trauma. And then lastly, what we'll touch on today is collective trauma. And this is when an entire community is impacted and kind of, the sense of normalcy is really jeopardized. And that can come in the form of disasters, natural disasters, what we're seeing in Florida right now with hurricanes. It can also come through pandemics, what we experience with COVID-19. So that's more of that collective experience of normalcy being really shaken for us. So I will pause here and pass it to Sarah.
Thank you, Alison. Sorry about that. So what we'd like to invite you to do is a poll, and this one's going to be in Zoom, and our hosts are setting this up. What we're interested in learning about is what type of trauma you may be most familiar with, either personally, professionally, or vicariously. And so if there's a trauma that you yourself are coming into this space today feeling more knowledgeable about than perhaps others, that's what we'd like to see. And hopefully our hosts will be able to set up so that we can see the results of this, so that you also can see who's in the space as well. Just want to check in with our hosts. Is that something that can transition to? Okay, thank you. There we go. So a lot less familiarity, it looks like, with sanctuary trauma, which Alison talked about as, going to a physician's office or a church or a school, but equal parts acute, complex, historical trauma experience or knowledge of, followed in close second by vicarious, secondary, and collective. Thanks for your responses there. So what we'd like to do now is share a brief video, a 5-minute video, to offer some backgrounds on what we call adverse childhood experiences. The video sums this up really nicely, and I'm going to make sure that we optimize for sound, and I'll mute myself for.
What does your parents' divorce have to do with your risk for heart disease? If your mother had a drinking problem when you were growing up, are you more likely to suffer from depression as an adult? Here's what you should know about ACEs. ACEs stand for Adverse Childhood Experiences, extremely stressful events that can happen to a child growing up. Some experiences are so stressful that they can alter brain development, as well as the immune system, increasing the risk of lifelong health and social problems in adulthood. The term comes from the Adverse Childhood Experiences Study, landmark research that shed new light on the root cause of everything from stroke and liver disease to substance abuse and mental illness. In the late 1990s, an epidemiologist from the Centers for Disease Control and a preventive medicine doctor at Kaiser Permanente set out to understand the association between childhood experience and lifelong health. They asked over 17,000 people in the Kaiser Health Plan in San Diego about their health history, as well as difficult questions about their experiences growing up. Anda and Felitti tallied up 10 different kinds of adversity in this largely middle-class and college-educated population. They were stunned to see how common ACEs were. 21% of all respondents were sexually abused as children. 19% grew up with someone who suffered mental illness. 28% had been physically abused. And 2 out of 3 respondents had experienced at least one ACE. The researchers next looked at how someone's ACE score, or the number of adversities they experienced, related to a wide array of serious health and social problems. They saw that the more ACEs someone had, the greater their risk for poor outcomes compared with someone with no ACEs. Someone with an ACE score of 4 had twice the risk of heart disease and cancer. Someone with an ACE score of 5 had an 8 times greater chance of being an alcoholic. And those with an ACE score of 6 or more, on average, died 20 years earlier. With every major problem they looked at in the ACE study, the risk went up for each additional adverse experience in childhood. As Dr. Robert Anda says, what's predictable is preventable. It's important to remember that ACEs are not destiny. ACEs are a tool for understanding the health of a population as a whole. For individuals, an ACE score can be a tool for understanding their own risk for health and social problems, and empower them to make changes for themselves and their children. ACEs tend to get passed down from generation to generation and are common across all income levels, races, and cultures. But increasingly, people of all different professions and backgrounds are coming together to discuss how ACEs affect their communities. They're finding new ways to treat and prevent ACEs. Many doctors are starting to screen their patients for ACEs as part of their medical history. more schools are becoming trauma-informed, considering the source of problem behavior when disciplining their students, instead of immediately suspending or expelling them. To learn more about interrupting the cycle of adversity and improving health and well-being for the next generation, please visit kpjrfilms.co.
Great. Thank you, Sarah, for sharing that video. And I just wanted to kind of sum that up in terms of what that means for our conversation today. So we really need to keep in mind that the ACEs study, and when we talk about ACEs, there are some limitations to it in terms of the 10 items you see on the screen right now. Those were the 10 kind of factors looked at in the original studies and in the original study in the 90s. But these 10 factors, there are so many other things that we can think about and talk about when it comes to adverse childhood experiences before the age of 18. But it was groundbreaking in a sense, because we do have that longitudinal look when it comes to these 10 factors on how it impacts health. So it really gives a good groundwork to our discussion when we talk about the people we serve, maybe what they experienced before the age of 18, but then also ourselves. So it said that 2/3 of Americans report at least one ACE, and this data really carries through today for Wisconsin as well. So we'll talk a little bit about that here. And when it comes to these 10 ACEs, so really when we see some dramatic impacts on long-term health outcomes is when there's 4 or more ACEs present. So we want to also pause and say this isn't a diagnostic tool. This doesn't mean that if I have 4 ACEs, I will get X, Y, or Z, but it just shows how risk is elevated the more ACEs that we have, and how this can be a tool for our own personal health as helpers, and then also to keep in mind for the people that we're serving. So if we do get a sense or people disclose, they have 4 or more ACEs, we're able to kind of use that as a lens of how we really need to work upstream and help all that we can to, put that prevention in place for negative health outcomes. So I'll let you just kind of take a look at some of the data on this screen. And then we'll look at some of the data for Wisconsin. So in the original study, 1 out of every 6 adults had 4 or more ACEs. So that's a big deal. That's that 4 or more tipping point when we see negative health outcomes elevated for risk level. And nationally, to kind of put some numbers to this, it's a lot of people. Over 33 million people have 4 or more ACEs in the US based on US 2020 census data. So it really kind of helps us understand, the commonality of our experience with ACEs and how we need to destigmatize the conversation too, to help people get the support they need. So in Wisconsin, the numbers also line up to that. So 60% of us have at least 1 ACE. So it's more likely than not that you do have 1 ACE as a helper, and then the people that you're serving too most likely have at least 1 ACE. And then 16% of Wisconsin residents report 4 or more. And then here's a quick look at kind of a county breakdown. Our Office of Children's Mental Health for the state of Wisconsin had a fact sheet in 2020 that looked at counties and percentage of adults reporting 2 or more ACEs. So not the 4 or more tipping point, but it does give kind of a look at the county breakdown of an adult answering the question, before I was age 18, I experienced, X, Y, or Z ACEs. The orange counties that you see are Adams, Juneau, Kenosha, Milwaukee, Menominee, Oconto, Washburn, and Winnebago. And then I'll pass it to Sarah to kind of give some more context to, how this fits into the conversation.
Thanks, Alison. I want to honor Kate Blanchett's question in the Q&A. How do you think the different types of trauma can affect people's trust in institutions? Social determinants ask us to be hard on systems and soft on people. That's a really important distinction that individuals can't change entire systems, and that some of our systems are actually set up in such a way that creates social determinants of health that disparately impact different people. Social determinants of health are essentially conditions in which people are born, live, work, learn, worship, and grow. So strengthening resilience in the face of these difficulties relies on our having each of us as individuals positive social determinants in our lives, such as supportive community, financial well-being, healthy relationships, and safe places to live, learn, and work, as well as access to resources, quality schooling, education, healthcare, healthy food, all of these things. So we'll talk at a very high level here about some of the aspects of social determinants of health. So first off, we can talk about people who are Black, Indigenous, or other people of color who may experience disparate impacts because of their race and ethnicity. Another group in Wisconsin are folks who are lower income or economically disadvantaged. Another aspect are people who live with disabilities, individuals who may be on their own or families who have members of their family with disabilities, and access to resources to participate fully in work and social lives can be disparately impacted there. Members of the LGBTQ plus community, depending on where you are, the inclusion can feel very different, and it's pretty different across the country. So that's something that factors in as well in Wisconsin. And then lastly, people with who are living within geographical barriers. So we think about folks who may not, who may live in what you may have heard referred to as food insecure or food deserts, where there isn't the same sort of access to education and support and resources.
And all of those categories that Sarah just mentioned kind of ring true in the data when we go back to the Wisconsin Behavioral Risk Factor Survey. You will see some trends that mirror the trends that Sarah just talked about. When it comes to ACEs distribution by sex, females are more likely to experience that 4 or more ACEs. So that's something to keep in mind. When we talk about race, exactly what Sarah just mentioned, you see that any ACEs here in the darker gray go up compared to the 0 ACEs for specifically our Black, American Indian, Asian, Hispanic populations at a higher rate than the white counterparts. When we talk about income, like Sarah mentioned, as expected, as income goes down, the risk of more ACEs go up, and then vice versa. And mental health outcomes. So frequent mental distress is having 14 or more bad mental health days in the past 30 days. So, in the past month, 2 weeks out of that month, you had some bad mental health experiences in those days. So that goes up as the number of ACEs go up. So when we talk about, our mental health right now, we can think about ACEs and how that plays into it. And then going through kind of the buckets of all the ACEs, when we talk about that category of abuse, sexual abuse, physical abuse, and emotional abuse, those 3 out of the 10 ACEs, emotional abuse is the highest reported in Wisconsin. So adults who are over the age of 18, reflecting back, emotional abuse rises to the top. You'll see sexual abuse here is only 12%, but that 12% is still 1 out of every 6 people. So, or 1 out of every 10 people, excuse me, of Wisconsin residents that experience that. So also important to keep in mind. And then the other kind of bucket of ACEs, these are the remaining ones of household dysfunction. You see that substance abuse in a household, so by an adult, a sibling, someone living with you before the age of 18, is the highest reported. So some big ACEs takeaways when we apply it to our life and our work, knowing that ACEs are common and highly interrelated, to kind of destigmatize this conversation and really talk about ways that we can work upstream to prevent ACEs is a really big piece that we can take from this. That groups are disproportionately impacted by ACEs. So we need to talk about health equity and structural systems, like we mentioned, of how we can have that big system impact to address some of these disproportionalities. And that ACEs do have a direct link to our future physical and mental health, but it is not a diagnostic tool. And that kind of goes into this conversation of there are things we can do, positive experiences that might buffer the impact of these ACEs. It might not remove an ACE completely, but kind of buffering a child around all those negative experiences does show to have positive impact on health later on. So our ACE score personally, but then also for the people we serve, does not equate to your destiny. We really want to take this information as a tool to really move forward with how we serve others and how we access our mental and physical health care as well.
Alison, it's so interesting. I think about what you just said, and I've heard that referred to as protective relationships. That if you have, for example, one parent who may suffer from mental illness or addiction, but another parent who kind of can hold the ground for healthy relating day to day, that second parent can be protective against some of the negative impacts of the effects of addiction and mental illness on the family. So thank you for bringing that up. We also are going to invite another poll just to sort of see how you're tracking. So the statement, fewer than 50% of Wisconsin residents report having at least one adverse childhood experience, true or false? We'll give everyone a moment to respond. Fewer than 50% of Wisconsin residents report having at least one adverse childhood experience.
And we'll give that just another 10 seconds or so.
All right, so the correct answer is false. We have, I think pre-COVID, we had 57% of Wisconsin adults who suffered from at least one ACE, and that number has increased to 60%, as you can see here. That means that 2 out of every 3 people that you work with, both in your workplace and the people you serve, have other stuff going on that may be informing how they're relating. Alison, I can't remember if this is you or me. Oh, okay, got it. So we're going to segue here and begin to introduce and talk about trauma-informed care. Trauma actually derives from the Greek word that means wound. So it essentially means that someone has experienced woundedness. It can be a product of extreme stress, and we often think of trauma as a disease of disconnection that lives in the body and often interferes with relationships. So trauma-informed care is essentially a culturally informed approach which acknowledges the pervasiveness of trauma amongst us in our workplaces and families. And it focuses on safety and trust so that we don't re-traumatize people in working with folks. I'll read this quote. "We need to presume the clients we serve have a history of traumatic stress and exercise universal precautions by creating systems of care that are trauma informed. Trauma is essentially universal. It's part of the human condition and shapes all of us. And so what does that mean? On our next slide, you'll see a question that that trauma-informed care encourages us to shift to in our minds, if not in directly asking, from the idea of what's wrong with you? Gosh, I'm having a hard time working with you. What's wrong with you? To, what may have happened to you? And whether or not we can ask that question directly helps us to at least hold in mind that somebody who may be reacting badly in the workplace or in terms of the people we work with in service, that there might be something else going on that we don't know. And even just holding that possibility in mind can inform how we go forward.
Thank you, Sarah. So I think that question is so foundational to kind of how we jump into the nuts and bolts of what makes something trauma informed, what doesn't. I think when it comes down to it, we can just go back to that question and really operate under that, the universal belief and assumption that we all have our trauma histories, we all have our trauma stories, and let's, kind of in our head think, well, maybe what happened to this person, not jump to kind of a negative lens of what's wrong with the person. So when we talk about that trauma-informed care, it's not a specific one-time approach or intervention or a therapy. There are specific therapies that are trauma-informed, but when we talk about it, we can be non-clinical and think of kind of a system approach and an individual approach of what we can do to be trauma-informed. So these are the 6 guiding principles that can really help us in how we, as perhaps a leader in a workplace, can shape a trauma-informed agency, but then also kind of one-on-one direct service. If you have a meeting with a client or a customer, what can you be doing with these 6 principles to be most trauma-informed? So to kind of break some down, let's take safety. So it does kind of go in order because without safety, you really can't jump to the other principles. So we need to create a safe and welcoming environment where people feel physically and psychologically safe. So physically, the environment, the lobby, the waiting room, whatever kind of situation a person is in. But then psychologically, do they feel like they can speak up or voice an opinion without feeling unsafe for having their voice be heard? Safety is also defined by the person being served. So we, as perhaps an organization, can't just deem something, oh, this feels safe, without that input of the person actually truly deciding if they, as the customer, patient, client, feels safe. Then we have trustworthiness and transparency. So once someone feels safe, then they can build and maintain trust among the person that is serving them, and that it's a professional boundary, but also transparent. So kind of how do we balance, professional ethical rules we need to follow as perhaps a helper, but then can we be transparent with how we come up with policies, how we define a process, how we clarify the roles in the organization? So that very delicate balance. Then we move to peer support. So how does our organization or process really tap into the peers to offer mutual help and kind of self-help? So can we use stories of lived experiences and people who have maybe stories that can be integrated into the ways that we deliver the service? And that may be applicable more so in certain situations than others. Then it moves on to collaboration and mutuality. And this is making sure that we have kind of a with versus a to. So can we do this with the client, with the person, with the team instead of to something? So how can we shift that kind of relationship dynamic in everyday conversation, and then also big picture policies? How can we be more inclusive of the person receiving the services? to help them kind of direct their care. And that really goes into the empowerment, voice, and choice. So that really is validating the strength of the individual being served, and helping them kind of have the voice and what's next in their, let's say, treatment plan or action step. What can they do to kind of take on that ownership and have some empowerment and autonomy. And then we have cultural and historical and gender awareness. So kind of going back to those different types of trauma, being aware of the historical, generational, and racial trauma that's still at play today, even if perhaps an incident happened prior to a person being born, how is it still pervasive in our systems and us in our society? And how is our organization leveraging a healing value, traditional cultural connections within the work, to really make sure our policies and processes meet those cultural needs of people. So those are, a quick overview of the 6 things that can be integrated, big level, small level, and something we can kind of keep in mind. Moving into then kind of a summary of the 4 R's. So you might hear in trauma-informed care, what are the R's? It's realizing that trauma has a wide impact on so many people. It's recognizing then the signs and symptoms of what trauma responses look like. We didn't talk too much about that today, but that can be a whole presentation in itself of, some people might react being, triggered through their trauma in a very hostile, anger kind of approach. Other people might retreat and shut down and not want to deal with it. So really ranges of signs and symptoms of what that trauma looks like. So kind of familiarizing yourself with that. And then how do our policies and our programs respond? By fully integrating all of this knowledge about ACEs and the data and the numbers. How do we really put that into our approach to work upstream to prevent trauma? And then knowing trauma is there, how do we not resist re-traumatize? So that's the resist piece. So how do we not make sure our physical and psychological spaces that we work in do not re-trigger and kind of replicate a dynamic of original trauma? So that's kind of a lot to take in, and we will have time for conversation. We're not done quite yet, but just keep in mind, those 4 R's and how that applies to your work, and if you have questions about what that might look like. So then we'll kind of jump into the DHS, the Wisconsin Department of Health Services, kind of take an approach on this and how we can integrate all of this great info into every public health approach, including working with partners like Covering Wisconsin. And it really centers around this key term of resilience. So resilience kind of received a spotlight over the pandemic. It became a buzzword of, being resilient through this hard time. And we just want to make it known that, resilience is something that we as a public health institution have really empowered people to think about before the pandemic. So Resilient Wisconsin was around before and really kind of took a spotlight during the pandemic. And it's a way for us to think about coping in positive and healthy ways when we think about trauma and ACEs. So let's kind of open it up for some discussion then about what is one way you are resilient, and I'll pass it to Sarah.
If I can give a quick intro, since we're going to be using the technology again. If you had trouble accessing this the first time for the word cloud, Mike and I just both sent it into the chat. That is okay. This is a bit for fun to use the word clouds. The Zoom polls, which we already did, are the polling questions that were important to pay attention to. In the chat, you can see that you can either go to that website that's there, or you can use your mobile phone to access the chat. And when you get there, you enter your name and then you can enter into the question.
Thanks, Tina. So I want to echo what Alison said about resilience. And I actually attended, before presenting here with Alison this morning, the YWCA Racial Justice Summit, which is an annual conference every autumn. And one of the speakers there was talking about resilience, how it is also the human condition. So it is the human condition to suffer trauma, and it's also the human condition to be resilient. So that's a really optimistic and hopeful thing. And I really want to echo what Alison said, that trauma ACEs and trauma isn't destiny, and that there is a lot of resilience in all of us. Otherwise, we might be curled up fetally right now, with whatever we're all dealing with individually and collectively. So in what way are you resilient when things are rough? Seeing things like staying positive, not giving up, remaining hopeful, having faith in yourself. That's wonderful. Being adaptable. I actually read something about how the IQ was created in the early 19th century, 20th century, I think, might have my dates off. Then EQ, emotional intelligence, became a big factor. And now the adaptability quotient is picking up some steam, because as we're seeing, there's just constant change and disruption, technological, ecological, social, political, etc. Adaptability is something. Prayer or meditation, faith, accessing our spiritual selves, another way. Staying optimistic, seeing a couple staying optimistics. I can turn off brain when I am with grandbaby. Oh, there's nothing more than being with a child to bring you back to the present. Their skin, their smell, and just that they're so here in the now, where all of us who are grown, we tend to become very cognitively preoccupied pretty quickly.
Sarah, are you trying to share the results to that polling question?
Oh, I'm so sorry. Have I not shared my screen? Maybe I wasn't. I apologize. Thank you, Tina, for letting me know. Yeah. So you can see that the answers are scrolling, and I so apologize for missing that. I'm seeing lots of changing outlook when possible, remaining positive and hopeful. I am seeing a bottling it up. Bottling it up, I know, can work in the short term. I've done that too. In the long term, that can be hard. It's sort of like, where does the bottle go when it's full? So something to think about there. Using life experiences to be understanding and helpful, being willing to work with difficulty and learn from experiences. There is a lot of wisdom in this room. Alison, I invite you also to call out what you're seeing.
I agree with you. A lot of wisdom, a lot of differences, and how we can approach resilience. And I'm seeing a lot of, individual level, which is perfect. That's what the question is. What's one way you are resilient? And it just makes me think, as a community of helpers, as an institution of covering Wisconsin, what are ways that we're supporting that workforce, all of you, to, take on these individual pieces and reminders and support from supervisors, for example, and maybe in other kind of working capacities you might identify with.
Alison, I'm seeing one that's jumping out for me, forged in trauma. I keep fighting, and I want to acknowledge that some of you here have yourselves experienced higher amounts of trauma than perhaps people that working beside you. And that ability to attend to self-care, and also potentially to have supports, familially, socially, and maybe even in the workplace. I know I'm really lucky that I've had a colleague who's a thought partner and a trusted colleague, so that, when there are inevitable mismatches in repair, we do that repair really quickly and trust the relationship, that, neither of us will descend into something that's unbridgeable, right? And because it's human nature to disappoint others from time to time. It's human nature to hurt other people's feelings inadvertently, but being able to repair that. And when you have a lot of trauma experiences prior with trauma, or maybe even currently, it's harder to come to work and feel like there's safety there. So I wish that for all of you, that you've got trusted colleagues in the space where you're doing your good work. this too will pass. There is something to be said for if change is the name of the game. Also, what does change is the hard stuff. Seeing a lot of reference to the spirit connection, prayer, faith, trust in God, or what you may believe in that's bigger and larger than yourself. And physically exercising to reduce stress, celebrating stubbornness. Whoever wrote that, I'm with you there. I'm pretty stubborn myself. So, Alison, what are you seeing?
Yep. I just love how there's diversity in terms of how we all stay resilient. And I've noticed a few connecting with family, and one about walking in the woods with family that is talked about a lot, about just connection with nature, stepping outside, going for a walk, how that can help us cope too.
Crying it out, right? Actually, I think about the comment earlier that, some of us bottle it up. Crying it out, even if you're alone, is a really great way to let the steam off on a very full bottle. So that can be a way. The reason we ask this question is really to reinforce that we all have things in us that help us get up and dust ourselves off and keep going. And it's different for everybody. What might work for me might not work for Alison, and vice versa, right? So part of this is really acknowledging that it's important to know yourself and what you need. I will say that with a little bit of humor, that I have always been a fairly intense person from the time I came out of my mother's womb. And as a kid and a younger person and an early adult, I remember being really annoyed when somebody would tell me to relax, right? Like, telling me to relax is not helpful, where it might work for somebody. So what is it for me? And, I resonated with some of the go for a walk, go for a run, meditate, reconnect with my spirit, the thing that is bigger than me, that's bigger than this human story that I'm telling myself right now. So also seeing laughing. That's another good thing about colleagues, trusted colleagues in the space, especially when stuff is stressful or we have something like a global pandemic that interrupts everything. That ability to laugh every day in the midst of stress and what might be traumatizing is really a blessing. If you've got people you can laugh with, that's something that can really support resilience. Having fun, yeah. So I'm seeing the answers slow down. I think I'll stop sharing and we'll go back to Alison if you want to pick up where we left off.
Great. Yep. So that was a great kind of exercise about the different self-care, individual level activities we can do as helpers. But we do want to kind of bring it back to that system level of, what is the state doing? What is your organization doing to really make system changes as well, not only to support the individual stuff, but to, build resilience on a community organizational level. And that's really that focus on helping our helpers and knowing that it's okay for helpers to also ask for help. So including all of you in the room today, that we want to really give those resources on our Resilient Wisconsin webpage to learn more about, accessing the help you need, as well as then some tools to give to the people you serve. So we're going to dive into a few little examples with Sarah before we enter that kind of discussion phase.
And I have to say, I love this quotation, and I really have great respect for Rachel Naomi Riemann, who's a physician at UC San Francisco. She says, the expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. When we have that expectation of ourselves or our families or our colleagues or the people we serve, we don't do anybody a service, right? Sometimes the simple acknowledgement of you've lost a lot can go a long way, just in seeing where people are. You can't fix it most of the time, but acknowledging that that people have suffered is a way of letting them know you see them. And so as we can do this with ourselves and with our colleagues, this is a really valuable thing. You're wet, you've walked through water. So we're going to offer a few strategies, and these are things that we're trying to employ in my workplace at UW. Strategy one is to understand that other people's behavior is often not about us. So I think about, and these examples came from my collaboration with a former employee assistance counselor who has since retired at UW-Madison. But she often talked about how, if you have a colleague who's intensely reactive and you really might be inclined to avoid them because they're just really unpleasant to work with, to understand that colleague, the reactivity may come from a way that they learn to cope with trauma as a child with a parent who was, as you can see here, abusive, cruel, passive aggressive, or mentally ill. And I also want to say mental illness doesn't always translate to cruelty and all of these negative things. So a caveat there. But in places where mental illness can create abusive tendencies toward children, your colleagues might be coming from a history of this. And so just knowing that, they're reactive, and to be able to let yourself off the hook and not center yourself, but be able to hold space for how can I lessen the suffering here, including for myself in the relationship, right? Without making it be about me. Strategy, let's see, what's next? Okay, so we also want to think about it in terms of power relationships, right? So there's a power distance between who we are and who our supervisors are in terms of their formal authority. And so if a supervisor is the person who's actually being difficult, for example, in times of upheaval, this could be triggered for them by memories of great destabilization in childhood with a family that had a lot of trauma. So again, it's easy to be angry with supervisors and to think they should know better because they're leaders. I just want to say they're human too. And everybody is sort of bringing themselves to a workspace through the lens of who they are and what they've experienced. And so having some understanding again that even with people who are in positions of authority in our organizations and to whom we report, that they may also be struggling is a way to, again, not make it about us, not center ourselves, and to really focus on shifting conversations and requests to nurture and foster healthy behaviors in the workplace. I think we may have and consumers. So all of you serve people, consumers, and you may have experienced folks who are really afraid to receive your help. They come in and it might be they might be in shutdown mode, they might be combative, they might be non-responsive, and that's really frustrating because you're trying to help. Knowing that the consumer you're serving might be struggling with PTSD, early developmental trauma, and that they may have major issues with trust just can help you learn to slow down and maybe find innovative ways to find out what they need and how you can support getting them what they need, and let them co-direct that with you, right? Which requires being present and seeing where they are. So that's something to consider if you've got folks that are coming to you for help and you're trying to help and it's not working. Partner with them to help them see how they can help you give them what you're trying to offer. The second strategy is when stuff shows up, pretending it doesn't exist doesn't really work. It might work in the short term, and it might work beautifully if you're working with somebody and you never have to see them again. You can avoid it, and and just say, I don't have there's not ongoing chance of my interacting with this person again. I'm gonna pick my battles and just not say anything and get out of the way. But that's not usually how it works in our workplaces with colleagues, with supervisors, and with people we serve on a regular basis. So when you notice things aren't going well, we offer a strategy around giving direct feedback. So feedback should always be private, honoring people's, as in Japan, there's a concept of saving face, that you never want to humiliate somebody with feedback in earshot of somebody else. Giving feedback gives folks an opportunity to respond to your feedback. And I think a lot, especially because I work in human resources, that if you give somebody feedback, you give them the chance to respond to and correct something before feedback would have to be reported and then be sort of blown up in ways that might have been fully avoided if there were a conversation in place. And that can build trust. The other nice thing is that when feedback is delivered well and the receiver hears it well, that both are encouraged to be their best selves. I know I've had that experience on both feedback giver and receiver. And that's definitely been my experience, that I feel like, yep, it's human nature to, we're all works in progress, right? And so just knowing that with humility and going into that relationally allows us to be our best selves. And then additionally, on the next slide, this also can inform our work cultures too. So when people give others direct private feedback, you offer opportunity for others to apologize for impact despite positive intent. And you yourself benefit from that culturally in a workspace that does this, that fosters these habits. It does allow us to understand other people's perspectives and to learn from their experiences and ours. One of the things that has come up for me over and over is that colleagues, supervisors, and clients are well-meaning 99% of the time. Most of us don't realize we're coming off the way we are. And then lastly, we can afford becoming a compliance organization instead of one that fosters trust, who, as I've said a couple times already, by nature of being human, do unintentionally offend, disappoint, hurt the feelings of others from time to time. So I know we have one or two more slides, and then we're going to open it up for Q&A. Allison, will you bring us home?
Yes, thank you so much for going over those examples, and we can jump to Q&A quickly, but just here is some resources for Resilient Wisconsin. We have a monthly newsletter called Trauma Informed News and Notes with the latest articles and research and happenings when it comes to being trauma informed in our work, and then a bunch of resources on our website. So I will pass it to Tina to facilitate Q&A if there's any questions.
Thank you both. Thank you for all your work on this presentation. There was a question earlier in the presentation that I know Sarah answered, but I wanted to give Alison the option to answer. Sometimes something that we interact with in our work as assisters, assisting people with health coverage, is a matter of trust. We get a lot of positive feedback that we build rapport with our consumers, but when it comes to trusting in institutions that are intertwined with getting them coverage, I find myself, even as a navigator, sometimes giving some pep talks. The question that came through, and that's all that made me think about, the question made me think about, was how do you think the different types of trauma can affect people's trust in institutions?
I think it has a really big impact. So that's why, as an institution, we need to do our best to recognize it and talk about it and integrate the conversation of ACEs and the impact that trauma has on our overall health into every kind of realm of public health. So what's really great about covering Wisconsin is you really probably see and touch it all when it comes to health questions and concerns. So I think, when working with people who feel that organizations are re-traumatizing them, taking a breath and talking to that individual to get their feedback. And if there is some kind of feedback or partnership loop that Covering Wisconsin can circle back with a specific provider, I'm not positive on the terminology there of who that would be. I think that would really help the system change and help us, address all of that. I hope that answers part of that question, I think.
There was another question that connected well with your answer there. It asked, in what ways can an assister be sensitive to the traumatic experiences of consumers, especially when they're actively experiencing them?
Yeah, I think the helpers on this webinar today are critical in that, to kind of be that hand to hold in a virtual sense of, we understand that this is a really hard, difficult, scary thing, and validating that, if you were in their shoes, it would be in a similar kind of feeling, and any feeling is really normal. Anger would be normal, sadness would be normal, and just destigmatizing that, it's normal the way that they feel, and that help is here, and that you can help them kind of navigate through that and try and work past that, and then also work with that organization that maybe created some of that disruption to do better in the future. And just like personal examples of helping, physicians, or helping healthcare institutions have like privacy and lobbies, that conversations aren't happening in front of other people. Like, if that's feedback someone gives, how can we as navigators assist that? I'll pass it to Sarah. There might be some more relevant examples that maybe participants want to share too.
Alison, thanks. I often think too that even doing what we did at the top of this webinar, how are you arriving? Actually seeing the person in front of you and pausing and letting the person collect themselves with you, so that, and to ask, how are you doing today? You might not say, how are you arriving, in a word, because that's very formulaic, but how are you doing today? Is there anything that would be helpful for me to know before we begin? Just to pause for a moment and let the person come into the space fully.
Thank you. We have 3 more questions in the chat and just a couple minutes to answer them. Here's a question. What is a good way to tell a client that you have gone through trauma or disabled as well, when they say something like, you do not know what it is like to be disabled?
Alison, I can go very quickly. I take care not to center myself when somebody's coming to talk with me. I think Alison may have a little bit more experience given the nature of the work that you do, but that would be my caution, coming back with, well, I do. Alison, what do you think?
Yeah, that balance of kind of professionalism, but then also vulnerability, I think, is key. And I think, having that pulse on, would it be appropriate right now to say, I do completely understand. I've lived through similar personal experiences. I can't give exact details, but I'm right there with you, and I am here to be your partner through this, because I do have a sense of what this might feel like, and I can help you find some answers. So I'm encouraging kind of integrating some of that peer piece if your position allows for that, in terms of the code of ethics that you follow.
Okay, so just that rapport and trust building can be enough in cases like that. Here's a question. How can workers take care of themselves when experiencing secondary trauma?
So I know at UW, and I'm aware that we're running out of time, so I'll kind of say this very briefly. We have critical incident support with our employee assistance office. I would say don't try to do this at home. That's why we have professionals in our spaces. I know UW has not only our employee assistance counselors on site, but there are very few number of them for all of our thousands of employees. We also employ Life Matters. And so I would check with your organizations to find out what kind of support exists in the environment for support of critical incident debriefing and processing, because that is tough. And that's not something we'd recommend you do alone on your own.
Yep, and I would agree with that. The debriefing is so critical. So if you have a direct supervisor or someone that you have those check-ins with monthly, weekly, whatever that might look like, or maybe you build that in to kind of process, debrief, and that supervisor too, that goes into a conversation about trauma-informed supervision. How can we build an organization where supervisors have those trauma-informed care concepts when they do meet with their staff, that maybe they don't just jump right into business and action items, maybe they give that space. How are you arriving today as an employee, as a helper, and having that safe space too. So something to recommend if maybe you aren't getting that in your current professional capacity.
And we had one final question. What are the signs of compassion fatigue for assisters to know when they may be getting overwhelmed by this work?
Alison, you and I could probably model when we've both been overwhelmed. I think we're probably different based on my knowing you. I get agitated. I start to kind of see mostly what's wrong and then build on that. And it's, you know, that in itself is a reaction that's not necessarily helpful. And that's a clue for me. I'm overwhelmed right now. I need to pull back and really exercise self-care here. How does it show up for you?
Yeah, I think that's a great example. And then I think another way to think about it is it's not just overwhelm with your to-do list. So when we talk about burnout, it just might be like capacity issue. I cannot get through these 100 to-do list items. But compassion fatigue is a step beyond that, of not only just, you know, overwhelm of the to-do list, but I'm actually starting to internalize some of the pain and the sadness that I'm seeing in the people I'm serving. And I'm taking that home. I remember a comment like leaving things at the door. Maybe if you stop being able to do that, that could be a sign of actual fatigue of that compassionate, you know, helping role that you're in.
Other things that show up, if you know, when we did the body scan, signs of compassion fatigue can show up physically. Your sleep starts getting interrupted. You're not sleeping well, you're waking up at all hours, can't fall back asleep. You start ruminating. I think that's what I meant when I said agitated. I start to ruminate about things very cognitively. Folks have all sorts of emotional ranges, crying more often, or feeling numb and shutting down emotion, right? In a way that isn't characteristic for you. So those are ways that they can all show up in myriad. A breach of faith, you know, a feeling, you know, if you're very oriented spiritually, a feeling of loss of that can show up too. So a lot of different ways.
Okay, and I know we are at time. Thank you both, Sarah and Alison, very much for all your work on this presentation. And thanks everyone for joining us. I think I'm handing it over to Alison Espeseth now.
Excellent. Well, thank you. Yes, thank you so much, Tina and speakers. This has been an amazing session. I have taken away so much. And, you know, I think I definitely even just take away this, you know, this is definitely we brought this to you for helping you think about this work, this really important and at times very trying work that you're doing, but also just how can this be applied in every aspect of your life? This is a difficult time we've all been experiencing. So that concludes our 2 sessions for today. We have 2 more for tomorrow. And before we say goodbye, I just want to announce the gift card recipient for today is Lara Garcia. So congratulations to Lara. We will be sending you more information in the coming days for that. So thank you again, everybody. Great to see you and have you participate today. And we will see you again tomorrow morning at 9 o'clock. Bye-bye.